Assalamualaikum warahmatullahi wabarakatuh. Today, I'm going to share about the CGM position in Ramadan. Before that, I would like to thank the organizer for inviting me to give this lecture. So, for the outline of my talk, I'm going to talk about the existing data, what we know so far about CGM outside of Ramadan for both type 1 and type 2 diabetes. And then we will touch about the data about CGM during Ramadan. Before we close, we will cover about the role of CGM and what are the recommendations for CGM use in Ramadan guidelines, as well as what are the newer CGM guidelines and what do they say about the CGM use in Ramadan. So, what do we know about CGM so far? We do have this landmark trial back in 2017 from Dexcom for type 1 diabetes, both the Diamond trial and the Gold trial. Both trials actually showed improvement in HbA1c as well as improvement in hypoglycemia in people with type 1 diabetes who use real-time CGM. With the Flash Libre or with the Flash CGM system, we also have similar trial in type 1 diabetes with the Flash UK and the Impact trial. Both trials were done a bit differently. One was done in people who are well controlled and the other one in people who are poorly controlled. In people who are poorly controlled, CGM improves HbA1c, whereas in people who are well controlled, CGM actually improves hypoglycemia and time below range. We also have other trial in type 2 diabetes, in the replace trial, Diamond type T2D trial, as well as the mobile trial. They are all done in people who receive multiple daily injection, as well as people who receive basal insulin in the mobile trial. In this trial, CGM shows mixed result. In the replace trial, there were no difference in HbA1c, although there was significant difference in younger cohort in the trial group. In the Diamond trial, the HbA1c improvement were quite modest at 0.3%, but both trials actually showed improvement in hypoglycemia. In the mobile trial, where they use a real-time CGM in patients with type 2 diabetes who receive basal insulin alone, the HbA1c was actually better at 8 months, and real-time CGM also improves the risk of hypoglycemia in people with type 2 diabetes on basal insulin. And then we also have more real-world data, especially with the use of the Flash CGM system, where in many countries where they provide real-time CGM as part of their medical or insurance reimbursement, we can see that real-time CGM or intermittently scanned CGM reduces the risk of hospitalization in both type 1 diabetes as well as type 2 diabetes. And this reduction in hospitalizations were mostly driven by reduction in diabetic ketoacidosis. So now we come to our main topic for the day. What do we know about CGM in Ramadan? So in order to guide my literature search, I searched about continuous glucose monitoring in Ramadan, and I had about 40 results for the past 10 years. So from these 40 results, what I found, there were 3 guidelines and concept statements, 4 review articles, 18 papers that look at the CGM to evaluate the glycemic profile during Ramadan, and this includes the safety or the risk or hidden hypoglycemias during Ramadan. There were 8 papers to look at CGM as part of an assessment to look at the effect of other intervention like insulin pump as well as structured education. And then there are 7 other unrelated articles. So, however, when I look for papers that look at CGM itself as an intervention to reduce the risk of the risk of complication during Ramadan, unfortunately, the data is still quite lacking. Nonetheless, we are going to review some of the papers that have been done in the past few years. These 2 papers that I'm going to share with you are both come in the same research group in Dubai by Dr. Hassanin Group. In the first paper in 2019, they published data about 67 insulin-treated people with type 2 diabetes who were without comorbidities. These patients were provided with structured Ramadan education, dose adjustment, and flash CGM before and during Ramadan. During this trial, the HbA1c improved from 7.9% to 7.7%, and the hypo and hyper risk were not increased during Ramadan, although there were higher risk of hypoglycemia in the multiple daily injection treated patients between noon and 6 p.m. When we look at the CGM parameters, there were non-significant trend towards improvement in the time above range from 68.5 to 60.8%, time in range from 27.9% to 34.5%. And when we look at the number of hypoglycemia in the pre-Ramadan, you look at number hypoglycemia improved from 4.3 to 3.9 events, and the duration of hypoglycemia also was shorter from 84.4 to 71.3, although all these numbers are not statistically significant. So in summary, in conclusion from this trial, we know that when coupled with the structured Ramadan education, dose adjustment, the inclusion of a CGM can actually improve the outcome during Ramadan in a way that they actually improve HbA1c and minimize the risk of hypoglycemia or hyperglycemia during Ramadan. And then the same study group also come up with another paper. But in this case, in this second paper, they actually expanded the patient selection. So now we have 169 high-risk people with diabetes, where currently now they included 29 people with type 1 diabetes, 68 people with type 2 diabetes on insulin, 26 people with gestational diabetes, 20 patients with CKD stage 3, as well as 26 patients with existing ASAVD. In this study, all patients received structured education, plus dose adjustment, plus and were provided with intermittently scanned CGM during and throughout the month of Ramadan, before and throughout the month of Ramadan. So, when in this second paper, the HbA1c improved from 7.6 to 7.3% during before and after Ramadan. The time above range improved from 61.8% to 56.9% during Ramadan. The time in range improved from 34.7 to 38.1% during Ramadan. The time below range were increased but not statistically significant. There were an increase of hypo event from 3.9 to 5. And then there was also an increase from hypo event from noon to 6 p.m. from 1 event to 2 events before and during Ramadan itself. So what we can see from this study is that the use of CGM during Ramadan does improve the HbA1c. It also improves the time above range and also time in range as well. However, there were more hypo being detected, most likely because of the lower blood glucose during Ramadan itself. So, moving forward, what do we know about current guidelines during Ramadan? We go back to all the way to 2021 in the IDF-DAR in the type 1 diabetes chapter, where the IDF-DAR mentioned that the use of CGM or flash CGM is superior to self-monitoring or blood glucose monitoring and should be the method of choice if feasible. Subsequently, this was followed by another guideline by the ISPAD in 2022, where they wrote about Ramadan and other religious fasting. In that guideline, in that document, ISPAD mentioned that frequent SMBG or CGM is recommended during fasting to minimize the risk of hypoglycemia and detect periods of hyperglycemia. The use of real-time CGM or intermittently scanned CGM may facilitate the adjustments of insulin dosing during fasting, and regular and more frequent monitoring of SMBG during fasting, especially for those who are on insulin secretagogues, and high-risk groups, although CGM is currently not routinely recommended for individuals with type 2 diabetes. And this is referring specifically to children and adolescents with type 2 diabetes. And now, last year, there was another paper written by the group from Asia Pacific. They call it the Asia Pacific Consensus 2023 Consensus Statement on CGM, where they covered quite comprehensively on the indication of CGM in the Asia Pacific population. And in that paper, they also covered about the use of CGM during Ramadan. So what they mentioned is that use of CGM may be considered in individuals with type 1 diabetes or type 2 diabetes on intensive insulin therapy who are fasting during Ramadan. But this is subject to patient factors and availability of resources. And then the use of CGM, either in a continual or intermittent manner, may be considered in individuals with type 2 diabetes treated with basal insulin, with or without glucose lowering drug. either oral or injectable, who are fasting during Ramadan. And this is also subject to patient factors and availability of resources. So what we know so far about CGM. Number one, we know from existing data that CGM clearly improves glycemic control, and it improves hypoglycemia risk in both people with type 1 diabetes and people with type 2 diabetes, especially those who are treated with insulin. In real-world studies, we also know that CGM, especially intermittently scanned CGM, can reduce the risk of diabetes-related hospitalizations. And most of this improvement or most of this prevention in diabetes-related hospitalizations were driven by the prevention of diabetic ketoacidosis. And this is especially relevant for our patient with type 1 diabetes or patient who wish to fast during Ramadan. However, the data on the use of CGM specifically to prevent complications during Ramadan, especially in a RCT manner, is still lacking. And we do need more data to guide our decision making in the future. However, despite that, with the current available data, we know that CGM can greatly facilitate diabetes self-management, especially so during Ramadan, where they need more frequent glucose monitoring and they need to look for hypoglycemia or hyperglycemia events to decide whether they should continue or terminate their fasting. And because of that, current guidelines are increasingly recommending the use of CGM during the month of Ramadan itself. So with that, I thank you and I open for question.